And we're live.
Terrific. Thank you. Back from break. Jen, thanks for being here. I know that there's been a lot of work going on to refine the definition for the stem cell bill and for stem cells in particular. And I know you've got something that we can look at, which we're hoping will be the last iteration. So why don't you put that up on screen for us and we can hear what the resolution is. And first I will share with folks that when I was on the panel on Tuesday, seems like 100 years ago, and we discussed the definition quite a bit as being critical to whatever we're doing on the bill, and then trying to make some changes. So I think what we're doing here will have some effect, not just in our state, but other states, on regulating these clinics. So it's all for you. Go ahead, Jen.
Okay, so this again is S22, an act relating to healthcare practitioners administering stem cell products not approved by the U.S. Food and Drug Administration. And I am Jennifer Carby, Legislative Counsel. We're looking at the definition now of stem cell and stem cell related products. So keep a lot of what we had in the other day, but with a little bit more of trying to tie it back in a bit to this idea of stem cells. So stem cell and stem cell related products would be any articles that contain or consist or purport to contain or consist of one or more of the following when intended for implantation, transplantation, infusion, or transfer into a human recipient, and when intended for use in the diagnosis, cure, mitigation, treatment, or prevention of any disease or condition. And then I've added in based on or in connection with a proven or purported attribute of stem cells. So trying to tie it back in a bit there. And then I've added in some language around bone marrow. This is a question Senator Hardy had that was also some feedback received from medical professionals. So this would add it to the list of including, I think, oh no, it's the following list. So human cells, including cells from tissues such as bone marrow, adipose tissue, amniotic membrane, umbilical cord blood when not autologous or in a first or second degree relative, placenta and other tissue or cell sources, intracellular or extracellular components or vesicles, or amniotic fluid. And then we'd have a carve out that says, for purposes of this chapter, stem cell and stem cell related products does not include the use of whole blood or blood products for routine transfusions or use of, and I'm not going to get this right,
hematopoietic.
If you could say poetic in there, I'm good. It's words. Hematopoietic stem cells for reconstitution of bone marrow after treatment of blood related cancers or diseases such as leukemias or lymphomas.
That's good.
So that would be that definition. The only other change, I think, is reflecting that suggestion from the Attorney General's office to be more specific in as far as the consumer inquiries. So this is on the written notice, must include information on methods for filing a complaint with the applicable licensing authority and for making a consumer inquiry, including to the Attorney General's Consumer Assistance Program. And then, is there anything else? Oh, yes, and then one more. This is the list of non-applicability. The provisions of this section do not apply to, and just some fine tuning around the language here from, this again was a recommendation from some of the healthcare providers. So a healthcare practitioner who has not documentation, but personally received a formal or informal determination from the U.S. Food and Drug Administration stating that approval is not necessary for the practitioner's specific usage of the stem cell or stem cell related products. And I think that really is it. Yes.
Okay, questions for Jen on the bill and the new sections in particular, but on the bill as a whole.
What might be some of the products that they could use that don't need
approval from the FDA?
I don't think I'm in a position to answer that question.
That's a very good question, Senator. The difficulty with this one is knowing what is approved, what's not approved, and what doesn't need approval. So the things that don't need approval, Jen has attempted to capture in the end with the transfusion piece. What does need approval or doesn't need approval is that little loophole section we heard about on some minimal treatment of homologous cells, your own cells, and then taking it out and swirling it around and putting it back in. So that will also be a question for A, the FDA, and B, ultimately, if there's a significant issue, could go to the courts. But what Jen has tried to do in conjunction with the scientific brains out there is to narrow the definition so we're not capturing things that don't need approval or have been approved. That's probably the little loophole piece is the one that we're concerned about.
Right. And I think that some of the concern from the provider community after the last definition was that it didn't tie back into things that people are treating as stem cells. And so it was really so broad that all kinds of things that nobody was claiming were stem cells would fit under the definition and then require disclosure, even though they were, and it was sort of misleading to disclose because it didn't have anything to do with purported attributes of stem cells.
Okay.
But as far as what products or materials are out there, I don't have a good answer for you because I just don't know enough about the practical application of stem cell products in the medical community.
Yes, and some of it is based on the products themselves, but some of it will also be determined by the scope of practice, whether or not someone is allowed to use certain things. So there's a lot here. What we're doing, I think, is really establishing a basis for determination out, in the courts or through the FDA.
Okay. The only thing I can think of is saline solution.
I'm going to have to, wait a minute. I can't hear you because I've got jets going over once in a while. So if you can speak directly into your microphone.
I just said the only thing I could think of that wouldn't need approval would be like saline solutions or, something like that.
Well, but I don't think that's derived from human cells.
Right.
So, yes.
Plasma.
So I suppose, yes, that is something that is outside of the scope of the bill. If you're trying to figure out what's left, I think there's a lot that's left that's outside the scope of the bill.
Right.
Thanks.
Trying to narrow it down to those clinics that are purporting treatment for some really complex diseases like multiple sclerosis or rheumatoid arthritis or ALS. I mean, they're all lumped in there and just, it's tough. It's very difficult. All right. Any other questions for Jen? No? How do we feel about the bill as it currently is, understanding that there are some things that are beyond our comprehension, given that the area of expertise is a pretty narrow area of expertise in the research and medical community. But in terms of the narrowing the definition as we've heard it, and then the protections that are in place for patients and to ensure patient safety, how do we feel about the bill? I mean, I think we should consider voting on it. We don't have to do that right now, but sometime today might be a good thing. Go ahead, Ruth.
Jen, first of all, thank you for all of your work on this complicated bill and all of the extra miles you went to. Well, I mean, I'm sure you were just sitting in the same place, but the virtual miles you went to get the definition set. So I really appreciate that. The accuracy is obviously helpful in this case. I think I'm ready to vote on the bill today if everyone else is. It'd be nice to get it off our docket.
Anybody else? Does anyone disagree with that notion? Is there an interest in voting right now, or do you want to wait? Right now? If you want to vote right now, just raise your hand as a straw poll. Oh, good. I was hoping you'd say that.
Our
Okay,
clerk
so
ready with the pen in his hand.
he
I
is.
just asked Nellie to send me the worksheet.
All right. So before we vote, we need, this is a strike all proposal amendment. What number is it, Jen? What's the new edition? What's the new draft?
Sorry, I was muted. I think it's 2.1.
Draft 2.1 S222 strike all amendment.
Yes.
I
And
need
I'll
a
take
I
out
need
the-
a motion. What
I'll
is it?
clean it up. I'm going to clean up all the highlighting.
Okay, all right, that's good. And we could get that posted on our webpage ASAP, because I think there are a lot of people out in the real world who would like to see it. I need a motion. Senator Cummings.
Yeah, I'd move that this is what, S 24? 22. Okay, I move that we strike everything after the enacting clause of S 22 and replace it with draft 2.1. And can I do that's the first to amend, right?
Yes, it is. And then if you, I think, let's do.
Can I do and as so amended that?
Yeah.
It pass?
Yes.
Jan hasn't said no, so
Is it
that's the
Isn't that-
motion.
No, that's,
yeah, I think that's it.
that's my
2.1?
parliamentary procedure. Yes. Masons, go ahead. So that's your motion? Okay. All right, discussion. Somebody else wants to vote.
Yeah.
All right, Mr. Clerk, please call the roll.
Okay. At this time, I will call the vote. This is for Senate Bill S22, version 2.1. Myself, I vote yes. Senator Hardy,
Yes.
Senator Cummings,
Yes,
Senator Hooker,
Yes.
and Senator Lyons.
Yes.
So I have a 5-0 vote, all in the affirmative for S22. Is that correct?
That's correct. Thank you. Good.
Okay.
Thank you, committee. This, I understand that this has not been an easy bill. In many ways, it's also not been a difficult bill. So I think there's a lot of motivation on this one. So
I
Senator,
just sent it for a final edit.
okay,
Because I hadn't sent it the right. So as soon as I get it back, I will send the clean copy to Nellie for posting.
excellent.
But the text should not, right now the text is what you voted out. I just
Yeah.
took out the highlighting.
Yeah, okay, that's good.
Senator Lyons, you're reporting, right?
Senator Hooker is going to report. She's
Senator Hooker is going to report.
She's going to be great. No, she's muted. Notice that's how she's going to report.
Really.
Yeah, no, you'll
nothing-
be fine. And as I said, I will send you my little PowerPoint information that'll help, and then
Okay.
you'll be
A
good.
question on procedure as far as getting the bill to the secretary.
Yes,
How
So-
does that?
the clerk you now have the vote. You will get a clean copy of the bill, and you can get that from Nellie. then you send the bill, the reporter, and the vote to Secretary Bloomer. And once he has that, then it will go up on the calendar, on the notice calendar. So you're responsible now as reporter for sending the bill, the final vote, and your name as reporter. That's it.
Okay. Thank you.
Okay. All right. Thank you. Oh, that felt good, didn't it? It's a relief. All right. So, and when we come back a little bit later, Jen, Ameren is going to come back probably around 11:10 in that area, and we're going to vote on another bill. Just a heads up for you as we're going through the flexibility bill. And at
Great.
10 o'clock, we have Sebastian Arduengo from DFR. I've said it 3 times wrong today. DFR. So let's look at the flexibility bill today. And then there were some places that we had stopped yesterday, and maybe you can help us identify those and the questions that were raised and whether or not there were suggestions for improvement.
And so are you interested in looking at the underlying flexibility bill or the audio only language?
Audio only, thank you.
Okay.
That's draft 3.4.
Yes. Yeah, just trying to make sure I had the right. Lots of documents around. All right.
Okay.
So, and just so you know, I'm working on realized I had a grammatical issue. And so I've started on a new version so I can make changes in that as we go along, if that's helpful. I'm just showing you what you have posted online. So we're all looking at the same thing.
Okay, good. Thank you.
So the first part again was the insurance coverage piece. We had the definition of healthcare provider and health insurance plan, which is
Yeah,
very
so
broad.
yeah, I think that there are places, I don't know that there's any, if there are concerns as we go through committee, and I'm going to ask Jen to scroll through fairly quickly. Stop us. Just say, I'd like to talk about this section, because I can't see you all. Maybe I can, hang on. Now I can see everyone. So if you see a place you need to stop, just raise your hand and we'll stop.
Okay, so 2 is the definition of it, or A2 is the definition of insurance plan. And then B1 and 2, I think are the main areas, or some of the main areas that we were focusing on yesterday. B1 is the requirement that the plan provide coverage for all medically necessary, clinically appropriate healthcare services delivered remotely by audio only telephone to the same extent that the plan would cover them if they were provided through in-person consultation. That's the coverage piece.
Wait, so this, I actually do want to stop, because this was where I was trying to get at some language that it's not only medically necessary and clinically appropriate, but for access purposes, potentially necessary. The whole idea that what we've heard is people who can't get in because they can't drive or whatever, those are the people who we want to make sure have access to the audio only, or they don't have internet access to do the video part of it or whatever. So I don't know, I'm trying to think of what language, but something tight like medically necessary, but sort of like, I don't know.
So yeah, I
don't have a suggestion, but yeah.
Yes, that's a good suggestion.
Let me remind you that this is an insurance coverage piece, and I don't know how how the insurance company identifies whether the person has access issues in writing an insurance plan. So that may be better under the provider section of whether the provider delivers. But I see Senator Cummings has her hand up as well.
Yeah, I'm getting there. So I was just going to say the same thing, Janet. It probably should scoot down to the provider section. So Senator Hardy, bring that up when we get there. Senator Cummings.
Okay, this is the one that has the big red flag. It
Well, this is the
says,
coverage piece. We haven't gotten to the reimbursement part. Are you,
okay, I thought I saw surface covenant.
so this is
Okay, if
coverage.
this is coverage, all right.
It's literally the next paragraph.
It's the next paragraph.
Yeah,
all
I
right.
just want to make sure we're separating the ideas of what's covered from how much is reimbursed.
Everything's covered.
All right, now everything's covered.
Currently everything is covered as long as it is medically necessary, which is really the standard for health insurance coverage. And then clinically appropriate is the piece about whether it really is appropriate to be delivered by telephone. And so we're flagging the access issue for the provider side. And now we are looking at reimbursement. So then 2A is the part I think Senator Cummings is interested in looking at, and that is the requirement that the plan provide the same reimbursement rate for services billed using equivalent procedure codes and modifiers, subject to the terms of the health insurance plan and provider contract, which is a little squishy area there, I think.
Yeah,
Regardless of whether the service was provided through in-person consultation with the provider or by audio-only telephone.
Let me ask this question. So when it says insurance plan and provider contract, I understand that these contracts, and we can ask DFR about this when Sebastian's in, but these contracts are pretty restrictive and they're quite long. And so there could be something built into the contracts that are coming up during the data collection year that would specify the conditions around audio only. And I think that's what's implied in that.
Go ahead.
ahead.
It says at the same rate as an in-person visit. It is very seldom that the legislature sets a rate. That's usually done as a negotiation, and then Blue Cross Blue Shield has to go through a rate setting procedure. But we've already told them what the rate will be for all audio only.
Right. So you would be locking in the
That's right.
reimbursement rate to the providers, which then would potentially have an impact or could have an impact on the premium rates. That's the rate setting process. There's no rate, there's no provider rate negotiation process that is public. That, you know, that's the contractual issue.
Right. It's never, the provider rate is not discussed anywhere publicly. It's between the provider and the insurance company. And sometimes the insurance company will give a provider a contract and say, this is it, period, sign it or don't sign it. And we understand that. And sometimes that's a point of concern for folks and lack of transparency, but that's a whole nother issue. Senator Hardy.
Thank you. And I don't know, Jen or Ann might be able to answer this question. This talks specifically about in-person and audio only. It doesn't actually mention audio visual. So
that's in a separate statute?
It's a separate part of our.
Right. No, I know, but here, my question is it possible that they would be reimbursed at a rate for in-person and audio only that's the same, and then the rate for audio visual is lower?
No, that's what I meant. It's in a different statute. There's a parity provision in the telemedicine statute that is set until 2026, I believe.
Yep.
And that was through Act 91 last year, the first COVID bill. So the telemedicine statute says, at least for a time period, a time certain, telemedicine audio visual gets reimbursed at the same amount as in person. And then this provision would also be saying for a separate time, slightly shorter time period or some time period, audio only also gets reimbursed at the same as in person. So all three of those would be getting reimbursed at the same rate.
Got it. I see. Okay. Thank you.
Yeah, so we passed that bill last year, and it may not have been something you would remember, obviously, so.
Right, and there was a lot of discussion on the
Yes.
reimbursement parity for that, especially in the House Healthcare Committee, even before it came over to the,
Right,
so I think you had your own discussions, but it
yeah, it was a lot
long
of work.
discussion in the Healthcare Committee.
Okay,
And so to also to respond to one other thing Senator Cummings mentioned, I'm aware of one other place in statute where the legislature has specified something around reimbursement amounts, and that is in the vision care providers, that it requires the same reimbursement to various providers for the same service, regardless of whether they are an optometrist or an ophthalmologist. That's the only other place that I'm aware of where there has been specification of the amount. Although back when you did Catamount Health, everything was set based on a percentage of Medicare. So not without precedent, but it is not. Senator Cummings is right that there is not much in statute that dictates the reimbursement amounts.
but then remember, this is not forever. This is a temporary, this is temporary. And when we hear from Sebastian, again, we'll look at what the timeline is or could be. All right, and Senator Hooker.
Thank you. And as much as we're saying parity with in-person visits, these contracts are all different, correct? With different different payers?
Presumably, we really don't know much about what the reimbursement amounts look like, but is your question, could the in-person rate be different for different payers? Yes.
Yeah. Okay.
And the other thing is that there are a number of conditions that are put into those contracts that include timelines for reporting and procedures. So in the contracts, I've seen a couple of them. They can be 30 pages, 10 pages, 12 pages long, and there are a significant number of qualifications around all of the care access that's there.
So I guess my question then is, if making parity with audio only and in person is helping the provider, easing the burden on the provider as far as paperwork?
I don't think it eases the burden as far as paperwork. It eases the burden as far as the finances. I mean, it pays the same amount as an in-person visit. You're hearing from some providers that there's the same amount of work involved, and there's no reduction in overhead costs when they're doing the mix of different modalities. So they want the same reimbursement rate.
Okay, thanks.
I did see Sebastian has come in.
Wait, please, Senator Cummings.
Okay, just to clarify my understanding, audio only is the one thing that is not a new technology. Doctors have been making phone calls for years. In general, they are have not been being reimbursed for phone calls. We are now saying that they're going to get reimbursed for, phone calls under codes, but for most phone calls, or many, at the same rate they are getting reimbursed for a full office visit. Now, when I go in for an office visit, somebody checks my weight, they check my blood pressure. And, there's things that happen that will not happen on a phone call. The insurance company, and remember, we're looking at a very small subset of insured people. Basically, those on the exchange, and I'm not sure how the adjustment, but when we adjust something on the exchange, something else has to move to keep that 80-20 or 10-90, whatever your ratio is, in the larger group market. The insurance companies are saying, let us ease into this. Let's see how, when we get out of crisis and people can come in, and they're not afraid of catching a deadly disease, how this works out, and let us keep data, and we'll pay, but we don't necessarily want to have to pay at the same rate of a full office visit. Or there's the opportunity to say, we will do this as long as the centers of Medicare and Medicaid allow it, because once they don't, we lose the data on a huge number of people that we want to collect it on, the poor and the elderly, who are most likely to need telephone.
Senator, I'm going to.
I'm trying to figure this.
Okay. What I'm going to suggest is that we have Sebastian Arduengo with us from DFR, and I think his schedule might be complex today. So let's move to him, and we have questions to ask him from our testimony yesterday and continuing discussion. So I hope you'll understand that we need to interrupt you at this point and move to DFR so we can answer some of the questions that we've had. Okay. So Sebastian, thank you for being here. It's good to see you again.
Good to see you, and good morning to everyone on the committee. Sebastian Arduengo from the Department of Financial Regulation, and I don't have any prepared testimony this morning, but I am prepared to answer your questions about the audio-only study that the department conducted over the summer and the legislation that's now before your committee.
Okay. So I think that you were asked to respond directly to, let's start with the timeline first for the data collection. And I think that we asked you the question about whether or not the timeline that's in the bill is overly long, or whether we can compress that timeline to begin in October and end in October. So we're trying to sort out what makes for an appropriate period of time. So maybe you could start with that.
Sure. So the short answer is that an October timeline would be doable, but it wouldn't be ideal for a couple of reasons. First, it's hard for the carriers to implement changes in reimbursement in the middle of a plan year. Usually changes are implemented between plan years because all the plans change. And I think secondly, we don't know when things will normalize as far as COVID-19 is concerned. So I think right now and for the foreseeable near-term timeline, there are a lot of people that are foregoing in-person engagements of all kinds because of fear of the virus. And if we go with a compressed timeline, that mentality might skew some of the data we're trying to capture.
Okay. And in terms of the work that DFR has done with the working group through the sort of the summer and fall, is it your understanding that the proposal we have for collecting data would be sufficient time for us to learn about the effect of audio only, given the sort of the conditions that and guardrails that are currently in the proposal?
That's right. I think a year of utilization data will tell us effectively whether and to what extent premiums will increase as a result of covering audio only services. You know, as Senator Cummings noted, these services have not traditionally been covered, and we don't know, and there's not a lot of research out there about whether when you do reimburse them, whether they replace in-person services. In other words, someone who gets an appointment over the telephone, they don't come in person, so the net effect on utilization is nothing, or whether they increase utilization, either because providers can schedule more appointments, or because people go in for both in-person and telephone appointments. So I think when we have that data, that's when we'll really be able to understand how coverage at whatever reimbursement rate the market or the legislature deems appropriate will affect rates.
Okay, and then I have another question. This is helpful to hear your response. So yesterday we heard from insurance companies that they were predicting a 2% premium increase as a result of audio only. But I think they were, since they haven't been tracking audio only, they've been tracking audio video. So I'm wondering, from your experience, then, does that mean that the percent increase or percentage increase that they're suggesting might actually reflect their experience with audio video? Without having the separate data from audio, how could we even predict what the premium or cost rate effect will be?
Right. I think right now it's effectively impossible to predict what the effect of premiums will be without knowing how utilization will be affected. Like I was testifying to previously, I think that health insurers and MVP employs very professional, very good actuaries, but we simply don't have the data at this point to know that premiums will go up 2% or 1% as a result of covering or reimbursing audio only services.
Okay. Right. So and just to wrap that up, so which is getting back to why we need data collection. So it gets to be the catch-22. We don't have the data, we need to collect it. Is it going to cause rate increases and so on? So Senator Cummings.
Thank you. Good to see you, Sebastian. Haven't seen you in a number of years. I think we all want to collect the data. Is it necessary to reimburse at full rate in order to collect the data?
No.
Okay. And it was just MVP, which insures a small portion of Vermont. Blue Cross Blue Shield is the larger. It's not just this service. Have we gotten data yet on the impact of COVID expenses that we've required insurers to cover, such as we've done away with co-pays, we've required that there are no co-pays for any COVID-related treatment. And we've also heard there's a general 3 to 5% inflation caused mostly by pharmaceutical costs. Have we gotten any of that data in at this point?
Yes, we have gotten some of that data in from Blue Cross Blue Shield of Vermont and MVP. And while I don't have that off the top of my head, once I dig through my email to find it, I can happily share that with the committee.
Okay, but there is an increase at this point.
Yes, the services that we've required coverage of as a result of COVID-19 have had a cost to insurers, but our analysis found that in general, these costs were more than offset by the drop in utilization in March and April of 2020.
So there's a balance there during the pandemic itself.
Right.
Yeah. Okay. Senator Terenzini has a question, and then Senator Hardy, I think you had your hand up.
Yeah, thank you, Senator Lyons. And I, I apologize for my absence earlier in the week, and I don't want to slow the committee down with a clarifying question. But if I understood you correctly, Senator Lyons, you just stated that during testimony from one of the insurance companies, we heard that there could be a possible 2% premium increase in insurance rates if the full reimbursement of audio only was passed into law.
That's what the insurance companies indicated. But then the question that I had was whether or not, because there is no audio only data right now, that, I mean, they haven't separated it out as far as I know, then that would have included the audio video that we had put in place last year. So that would be more of an assumption on their part as to what the utilization would be. So I'm just questioning that number.
And I asked this question with all due respect to our insurance partners and lobbyists, but could that be somewhat of a scare tactic to try to get us not to vote for this legislation? I mean, to me, it just seems like it's sort of an empty threat almost.
We'll leave it right there, Senator.
Okay, thank you.
All right, Senator Hardy.
Thank you. My questions were pretty much exactly the same as Senator Cummings' questions. And Senator Terenzini, I'm skeptical of that 2% because we don't have full information. It seems like an awful lot based on the testimony we received, which is, I think some testimony we received to 5 to 8% of visits are audio only. So I don't know how that could translate into a full 2% rate increase. It seems, I'm skeptical of it, but I think to Senator Lyons' point, we just don't have the full information because they haven't been parsed out between audio-visual, audio only, and the impact of the pandemic. There's just too much noise going on in the data.
Well, actually, no data yet. You're right. All right, Senator Hooker.
Do we know if there's a rate increase from like Blue Cross or MVP based on their losses over the past year?
They're just starting.
Sebastian, that's a question for you.
The rate process for plans on Vermont Health Connect is just beginning, but I anticipate that there will be some adjustment as a result of the pandemic. I think it remains to be seen how that will net out as far as the dropping claims versus the increase in costs. But again, our initial analysis is that the drop in claims more than makes up for the increased costs as a result of our emergency rulemaking.
Okay, and I'm sorry, I don't know the timeline. When do you expect rate setting to be finished?
The rates are typically filed in May, and at that point, we'll have a full actuarial analysis from Blue Cross and from MVP on exactly how the pandemic and the increase in costs and the drop in claims and the crazy year that was 2020 has affected rates or will affect rates in 2022.
Okay, thank you.
And so, but because that will be a whole separate rate setting event,
That's right.
then the data that's collected on audio only can be analyzed and separated out to understand the effect of audio only in the next rate setting process. Is that right? If after the data is collected, the data collection will include a separate audio only
That's right.
utilization. And so that we can then determine rate effect from that.
Yes.
Okay. Yeah. Thank you. Go ahead, Senator Cummings.
Sebastian, do we expect that utilization will go back once people are vaccinated? I heard we saw a downturn during March and April because doctors' offices were closed, but the utilization has gradually gone back up.
That's right. And I think what we saw going from the spring of 2020 to the summer of 2020 across all services, and not just in Vermont, but nationwide, is that the healthcare system only has so much capacity, right? So if there's a drop in utilization, it's not as if capacity can then go to 120% for the next 3 months to make up for it.
Right. It just goes to the usual level, the normal level, so
That's
to
right.
speak, and is continuous from that point on.
It returns.
Yeah, returns. Yeah. All right, but the goal here is to understand what effect, if any, the use of audio only will have on access, appropriate clinical care, and then, of course, cost associated with the patient as well as with the payers. So that's where we are. Your work in DFR, your suggestion is what? Based on the work that you did with the group, and we have the report, the working group report. I'm assuming that DFR has supported that report. I didn't hear that there was a concern.
So our long-term suggestion is that reimbursement for telemedicine be folded into our healthcare reform efforts, and that these payments be incorporated into value-based or capitated payment.
I guess my question then is this, because we've heard a great deal about value-based payments and the importance of that as we're moving forward with telemedicine generally, and now I don't know if this is a question for you as much as it is for the committee to think about including language related to that in the bill itself. So how would we move in that direction during the data collection period? I don't know the answer to that, and I don't know if you can help us answer that question. Sebastian.
So I think during the data collection period, our intent is to work with the Green Mountain Care Board and with One Care Vermont. And we had initial conversations with them while we were drafting the report, and I think one of the goals of this data collection effort will be to lay the groundwork for supporting moving these services into the value-based model.
Right. Okay, good. Thank you. That's helpful, and it does generate some thought about how we can put that in as a, as a goal within the legislation itself. I'm not sure that it's there, and Jen, you're going to have to help us find out if it is. Okay, Senator Hardy.
Seems to me that this is an opportunity when we're talking about audio only to both increase access to healthcare through different modes of delivery, especially for some of the most vulnerable patients, while also simultaneously reducing the cost of healthcare. And by having a mode of delivery that is cheaper and in some cases equally as effective if it's clinically appropriate and medically necessary. And it seems to me that if we're demanding that we reimburse on parity, we're actually potentially setting up the situation where we're not able to meet the second goal of reducing cost. And that's where I'm just really stuck on this in my head, is that we want to collect the data. We want this service accessible to as many patients as possible. And I also want to see if it's a possibility for a way to embed savings into our healthcare system. And it doesn't seem like that's what we're doing with this. And I hear from the providers that they don't feel like they're reimbursed well enough, and that they're not able to reduce their costs at this point. And I get all that. I also just feel like if we're setting this up the way that it's set up in the bill, it's not laying the sort of goal of reducing the cost of healthcare, which we've seen is just immense in our state at every level and for every sector. And I'd rather just sort of see if we can just change the focus a little bit of our effort to say, we want to collect the data, we want access to be better, we want this service available, you've been doing phone for years, you know how to do it, we want you to be reimbursed if you're doing phone care. Sure, yes, absolutely, but we're not sure yet what reimbursement rate that should be. And first we need to collect the data before we make an assumption about what that should be. That's where I'm stuck on this. And I think that, others on the committee, I see Senator Cummings nodding her head, and yeah, so I just,
okay, so listen, we get it. We understand. This has been the sticking point right along. The question, what we're trying to do is to understand what's in the bill that puts guardrails around that parity reimbursement. So it's parity for those medically, clinically appropriate, medically necessary treatments based on codes and based on what's usually done. So if it's a substitute for an office visit and it's done by telephone, but the same thing is done.
It's not.
If the same thing is done, then it would be reimbursed at parity. But if it's a telephone call that isn't, the conditions in the bill would suggest the payment would be different. We haven't gotten to the provider section yet. But Sebastian, can you respond to the concerns that you're hearing from your perspective in DFR?
Sure. This issue took up a big chunk of our time in the working group too, and I think that's because there are policy arguments that go
Both
both
sides.
ways, as we just saw with Senator Hurd and Senator Lyons. As I testified to earlier, you don't need to reimburse at parity to collect the data, and our telemedicine statute, as it is sort of an outlier as far as our insurance statutes go, because I believe it's one of the very few statutes that actually sets a rate for services. Most other services are negotiated between payers and providers.
So if the, but you know, when we've heard this as well, but it's also for a restricted period of time, that then once the data is in, there will be an analysis done with Green Mountain Care Board, DFR, and others to determine how best to reimburse. My concern around not having some parity based on the codes and other conditions, my concern is that we lose access, and so we don't see the utilization rate that audio only can provide, and the access it can provide for patients. All right, so we've gotten into a lot of discussion, and it's never going to end. I think we've got some people who feel one way or the other. But Sebastian, do you have anything else that you can add that would help us get over this, the concerns that have been expressed?
I would just add that this is the reimbursement rate is something that the department has implemented in its emergency rule, and it's certainly not something that needs to happen in statute. And I think the past year has shown that we've been very successful in working with providers and payers to come to solutions that are, if not mutually agreeable, then workable. And we think we can do the same thing during the data collection period.
So what are you saying?
Yeah.
I'm saying that if you would like to punt the reimbursement issue to the department, we are happy to take that on.
Okay, so if we said a rate as determined by DFR, it shall be reimbursed at a rate determined by DFR. You could work with the providers and the insurance companies to find an equitable rate for different. Okay.
Right.
That's for one part of the whole payer community. Okay. But I also want us to remember that when we're talking about audio only, we're not talking about creating something new. It's not a new service. It's a new way of delivering the same service. Right. This is a new suggestion that we haven't heard before, but if we put it into the hands of DFR and the Green Mountain Care Board, which I would be loath to put it into one agency because of the multiple interests, maybe in consultation with, how would you say it, Sebastian? DFR in consultation with whom and what?
I think in consultation with the Department of Vermont Health Access and with the Green Mountain Care Board, which I think would reflect the process that we did for the emergency rule.
Right.
I think it's very important for us that the benefits that folks on fully insured plans get are no better or worse than folks on Medicaid, just because it makes things more clear for consumers and for providers.
Okay. And I know we worked very hard on the emergency rules together, and I appreciate the work that you did in particular on that. It was, it has really been very effective. So even at a time when you were becoming a father. So we appreciate that.
Thank you.
Yeah. Okay. So what I'm hearing you say is that if we punted on the parity issue and kicked it over to DFR working with DEVA and Green Mountain Care Board, that this might resolve the problem that we're hearing. I know it won't be the end of it, obviously, but it might help and relieve us of making a decision about what works and what doesn't work during this data collection period.
That's right.
Okay. Jen, did you get all that? Okay.
Yes.
Any other questions for Sebastian? All right. So Senator Hooker, yep.
But this keeps the timeline as it is in the bill?
Yes.
And just DFR will
We
be.
hear from DFR that October to October would be too compressed.
Okay.
Not possible.
I was just concerned that, there'd be sufficient time to collect the data and to process it and get back. So that sounds like a plan.
Yes, it also sounds like, given the process that, Sebastian, that you've outlined, it also suggests there can be some give and take and negotiation through the entire data collection period. Will
That's
that
right.
be? Yeah. So I really kind of like that idea. Because I think it benefits the groups that are so committed to one or the other. So it's a good agreement like that. I knew it was good to have you come into committee. All right, thank you. So why don't we go back to the bill, unless there are other questions for Sebastian at this point? Is there any value, Sebastian, I don't know what your schedule is, but you could hang on the screen and do some work, but if we have questions as we go through the bill, would you be available for the next?
Let me just check my calendar, but I believe I can stay on the line for at least the next half hour.
That's exactly what I was going to ask. That would be good. You don't have to be on screen, but if we reach out to a friend, you would be there.
I am happy to be your phone a friend, so I will stay on for until 11.
Terrific, thank you. All right, so Jen, why don't we put the bill up again? I think this is something that we can look at. So where would we put this piece that we've just, I think is the committee okay with what we, I'm going off here, but I have seen a lot of heads shaking, yes. So it's a comfort level.
I'm much more comfortable with having them deal with it than us putting it in statute. I don't think that's our job. So I'm more comfortable with them doing it, which is their job.
All right, let's.
So what I'm looking at then would be to just take out subdivision B2 in its entirety that speaks to the reimbursement amounts. And then later in section 3, so bypassing the provider stuff for a minute here, restructuring this section here so that it has DFR in consultation with these folks, not only determining the appropriate codes and modifiers to be used and taking out this reference to the reimbursement parity, but also determining the amount, the reimbursement rates, at least as they apply to health insurers. And then I don't know what you want to do for Medicaid, if you want to specify or try to specify the amount, or just let Diva figure that out, which means we then don't have to, okay.
Yeah, that'll be a Diva. Let Diva figure that out.
That's what I assume. I mean, it can't be DFR is all I'm saying. DFR can't
No,
tell
it cannot be. And
Diva
that's
how
why
much to pay.
DFR is one thing. It's one set of payers.
Right.
It's not everybody.
So that's sort of what I've been starting to sketch out here is what that would look like. And I'm happy to run potential language by Sebastian for his
Okay,
input too before.
perfect. That's
We're
good.
hearing
Thank
about
you. And so then I'm sure we'll hear from folks on this and their comfort level of this. The group that was here with us yesterday, I'm sure will be reaching out. But I think this is probably a resolution that we can live with. The other thing is, as you get this completed, it would be helpful if I could have a copy and then communicate with Representative Lippert so his committee is informed about what we're trying to do here.
Sure. And what time period do you want? I mean, would you be having DFR determine the reimbursement rates, I guess, through that same period we had talked about through 2024, so that you have the information come back to you during the 2024 session and you can make changes at that point? Okay.
I think, rather than set a date certain for that decision, I think because this is such unknown territory, it allows for some flexibility within the data collection period. So we could see modification, I don't think we'll see a lot, but because of contracts and so on, but Anne, go ahead.
I think Sebastian said they're just starting now to develop rates. And those rates, it's the next plan year, they all go into effect at the same time, and you can't, it's a contract, so you can't change rates until next year.
Right. So there'll be a period of time for that discussion to go on before the next calendar year. So it's a calendar year collection.
Right. So if the data is coming back to you to consider during the 2024 session, Senator Cummings, are you thinking that DFR needs that ability to affect the reimbursement rates through 2025? Because those rates will be being developed during the 2020, while you're starting the 2024 session?
I don't know.
Sebastian, if you have thoughts on
This is
that,
beyond
let me
my
know.
pay grade.
Well, okay, so the question is, what's the timeline for decision making on the sort of the final?
Right. I guess what I'm thinking is if DFR's authority to determine the reimbursement amounts ends at the end of 2024, but the premium rates have to be established in, around now in 2024 for the 2025 plan year, then DFR may need to have proactively set those rates already, the reimbursement.
Sebastian, we need a friend.
Yeah, do you know
Sure.
do you know what I'm asking, Sebastian? And do you
Yes.
have a thought? Good.
So the study would start in plan year 2022.
Right.
We would have preliminary data during the 2023 legislative session, and then the legislature could make whatever changes it deemed appropriate for 2025 and forward.
Okay, so you think having the authority through plan year 2024 for DFR works.
Yes.
Okay, very good, thank you.
That's good.
Can I
Perfect.
ask a question?
Sure.
I don't know who this is, if this is Sebastian or Jen or whom, but I'm still unclear what exactly the decision that the legislature would have to make at that time would be. Is it whether or not we want to continue with audio only, how we want to reimburse it, what regulations we may want or need, all
I
of
think
the above?
yes.
Yeah,
Yes,
so
we
whatever
don't
you
know.
all
want.
of those questions, or we could choose to do nothing and say the way it's been working is fine and we're good with that.
Right, so I think the only thing, if you're having DFR determine the reimbursement amount through plan year 2024, your decision to do nothing would then leave it as a negotiation between the payers and providers after that. So you would have in statute that audio only has to be covered to the same extent as in person, if it's medically necessary and clinically appropriate. But you would not be putting anyone in state government, whether the legislature or DFR, in charge of determining the reimbursement rates after that date, after
I see. Okay.
2024.
Okay. So that would be maybe the trigger for us to come back and decide to do something, because that authority for DFR would be going away.
Right.
That's right.
Okay.
And you would also have the report with data in it to understand what the utilization has been and potential impact on rates. And you may want to make other decisions based on that as well.
Okay. Thank you.
And part of what we're looking for here, beyond the rates, because it's been all about money, but it's also that we're getting data about access and we're getting data about quality of care. So there's a lot of information that we'll be getting that informs rate setting, co-pays and so on. So we need to be clear, and that gets to VPQHC and the work that they're doing. So so I guess we need to make sure that the language that we have in the bill continues to identify the importance of access and quality within this whole audio process. And I don't know if we have that. I'm sure we do.
You have the reporting is supposed to include utilization, quality of care, patient satisfaction, and then I'm gonna put something different in around, because right now it says, and the advantages and disadvantages of reimbursement parity. I don't think that's not the way to describe it, but you may still want information on reimbursement amounts.
Yes, absolutely. And then, so I guess the question, Sebastian, for you is, does it make sense at all to have the language would include other interested parties? So that would be folks from VPQHC or other places that are collecting quality metric information. Okay.
Yep, that
Okay.
is fine, and is honestly in line with what we've already been doing.
Yeah. Okay.
Questions? Madam Chair,
Go ahead.
Could we add some language about promoting affordability of healthcare in the report? I mean, we have the thing about reimbursement, but I'm thinking more affordability for patients and affordability for just the healthcare system overall. Does it promote affordability or not?
Well, does that make sense? Or is it more about right now we're interested in having audio only? Let's think about that. Trying to determine how to pay for it and when it's used. Excuse me a minute.
It just seems like overall, that's a question we should be asking when we're looking at any kind of healthcare regulation, healthcare oversight, healthcare policy at this point is
I'm just trying to
quality and affordability.
I'm just trying to figure out what that adds to this. Is this then become a larger analysis that looks like total healthcare costs and then the effect of audio only on the total healthcare costs? And I'm just wondering if this is the place to do that. I agree with you that every time we look at healthcare, we want to make sure that we're making it, we're working on quality, cost, and access. That's been the mantra. So, but maybe we could put that in we don't have findings. I don't know, let's think about it. What does the rest of the committee think about that? Hello?
I think that's in statute.
Right.
It's definitely an intent. I mean,
Right.
it's the total focus of the Green Mountain Care Board and One Care.
Right. Anybody else? Senator Hooker, Senator Terenzini? I'm not seeing you, so.
Well, I agree. I certainly agree that that has to be a focus of anything that we do with healthcare. And, you know, if there's a way of putting it in, fine. If, as Senator Cummings says, it's in statute already and it's understood, then that's where it is. My thought, it's funny, I'm thinking maybe this is going to boost the expansion of broadband so we don't have to worry about, you know, just telephones.
We're working on it.
Good.
Sending that, right, yeah, the VPQHC actually has done some good work on that too. All
So,
right,
I mean, I can certainly put something in about the report, including the impacts of audio-only telephone services on healthcare affordability, which sort of maybe is broad enough to
Well,
get at
if
both
we're
the
gonna
payer
say
side
that-
and the system side.
if we're going to say affordability, then I want to say quality and access, quality and cost. You know,
Well, you already have
Yes.
quality
yeah.
in there. You have patient satisfaction. We could do impacts on healthcare access and affordability.
I would rather put cost in because affordability implies we're looking at people's income and their ability to pay. If we talk about cost, then we're talking about overall cost of care. And so what the copays are and how much we're charging. And that's what this is more about. So I would say if we could put something in about patient access, quality of care, and cost of care. Does that, Senator Hardy, is that okay with you? Does that work in terms of what you're trying to get at?
Sure,
All
that's fine. Thank you.
All right. And that is an ongoing, that is our ongoing theme, our goal and concern.
And we talked a little bit about value-based. I mean, did you want to put some reference into that?
Jen, where can we put that? Because I do like that.
Well, we no longer need we had talked about it by saying it was an exception to reimbursement parity. I guess it's still in here for telemedicine. I think it still makes sense for telemedicine. Maybe it goes in with this idea of the report talking about appropriate reimbursement amounts for services delivered by audio only telephone, and in value based, sort of getting at this idea of that's sort of looking at the amounts for fee for service, appropriate reimbursement amounts for fee for service. But you're also interested in value-based payments, right?
Yeah. So yeah, we could say something about how to move to more value-based reimbursement.
Right. I mean, I think you want to keep the focus of this report on audio only telephone. I think otherwise you risk sort of veering off into general healthcare reform. But I think you could talk about the role of or rollover coverage of audio only telephone when using value-based payments, or,
Okay.
I mean, I think that's sort of, because I think a lot of people have mentioned that the issue to some extent goes away. The reimbursement issue goes away if you're using value-based payments and you're not just looking at the fee for service aspect.
Yes. Okay. Yeah. No, that makes, if you could put something like in that would help the sort of the rollover concept, that would be useful. Okay. Anything else here? Do we want to, finish going through the bill briefly? So, because and then we'll get to some closure on this one. I'm feeling much better about it right now. Let's go through the rest of the bill, Jen.
Okay, so we did skip over the provider part.
So the provider part then will change.
Oh, and actually, before we even get there, so you had the deductible part in the health insurance. They can charge a deductible or a cost sharing. You can charge a deductible copay or co-insurance for audio only telephone, as long as it's not more than what it would be for an in-person consultation. And then you have the health insurance plan shall not require a healthcare provider to have an existing relationship with a patient in order to be reimbursed for healthcare services delivered by audio only telephone. I know that was part of your conversation yesterday.
Let's go to number 3 first. Then would that roll into the work that is going on with between DFR and the stakeholders and the interested parties, or is this something?
Not specifically, because that talks about codes and
Copays.
modifiers and
Yeah.
reimbursement amounts to providers. It would really be up to the plan design about how much of the reimbursement to the provider came out of the patient's pocket versus from the insurer. I mean, this mirrors what's in DFR's rule right now and what we have in the telemedicine statute, but it doesn't mean it has to be the same.
Well, let's leave it unless we hear otherwise. I think let's be consistent.
Okay. All right.
And
you
then
get to
what
the
about number
established patient.
4? Number
Right.
4 has been attractive, a magnet for conversation. This is the existing relationship with a patient. I mean, given that we're now moving to a different way of assessing, moving away from the parity piece, this might actually be less concerning. And so I'm seeing, Anne, you're shaking your head. Okay, I leave it in.
Yeah, I mean, the one thing that came up was, except in care in cases of, in general, I would think that you should not be doing audio only with somebody you've never met and don't have any health information on. But there are, there's always the exceptions. I just moved here and I'm spiking 104 fever.
Yeah.
I can go to the emergency room or I can call my neighbor's doctor. She gave me his number, kind of thing.
Yeah.
Yeah. As a general rule, I would hope that doctors don't do this.
Yeah, and I think you're probably right. They probably don't, but you never know.
And we've also got mental health. I think mental health was the other
Yes.
issue that came up, that those kinds of crises. And that's the one place where an awful lot of it is talking.
Yeah.
That audio only can be truly helpful.
It also, in my conversations with some of the pediatricians and primary care docs, it's also extremely useful as an initial contact with young kid with younger patients. So the high school patient who's resistant to visiting someone, but feels really comfortable talking on the phone. So I think
Senator
that,
Lyons.
yeah, yes, go ahead,
Um,
Senator.
I'm sorry, I don't know if you can see me or not.
Now I can, yep.
This really, I'm a big supporter of this bill, but this section has really been the only sticking point for me. I'll echo some of Senator Cummings' concerns, but I think, for example, if you're new to the area, you don't have a physician yet, and you spike that 104 fever, I think the ER or an urgent care facility is sort of your go-to. I could, every doctor I know is full of integrity, and I would never question the motives of a physician. But you could see that 0.1% of a doctor, this could become quite the business for a practice in the wrong setting. And I still think that testimony we heard about laying your eyes on the patient for the first time and doing that weight and blood pressure and all that is really critical. So, not a deal killer for me, but really I would much rather see this little section gone from this bill.
Well, I think that it is important to the providers, and in particular, as Senator Cummings has said, some of the mental health counselor folks. And remember this too, Senator, it's a temporary piece. It is during the initial data collection. So this would not become a permanent fixture after the little experiment is done. So we would figure out during the process how important first encounter by telephone is. So I hear you. I hear you. I hear you. I think everyone has similar concerns. But we don't want to close the door on the cases where it might be critical.
Thank you.
Think about it. Yep. All right, Senator Hooker.
I know that when we first looked at this bill, this section kind of jumped out, and as Senator Tiranzini had commented, one of the things that was concerning was prescription drug, the ability to prescribe. But we know, I believe, in the language that says that opioids are not going to be prescribed.
No, we can't do that.
Is there any language that limits what can be prescribed?
Well, we have a lot of prescription drug.
Right. There's a lot, nothing in this section, but that would again go to some extent under what is clinically appropriate.
Yeah.
We also have opioid prescribing rules from the Department of Health and requirements to query the Vermont prescription monitoring system prior to prescribing an opioid. So there is a fair amount in other statutes and rules on appropriate prescription.
And I do think that this is important for the mental health piece, and especially, as you mentioned, Senator Lyons, young kids who may not want to be face to face with a doctor, with a provider. So
yeah, it's tough.
Can we just do a carve out for mental health visits? I mean, that was one suggestion that
I know there are some concerns about with mental health parity, about treating mental health differently, even if it's to elevate it.
Yeah, and it could be not just mental health. Yeah. Yeah, I agree with that. I think there's going to be a lot of discussion over this whole thing during the time that requires pulling people together. So, and listen, we can hear back. We may hear back that there's a train wreck going on because of this section, but I sincerely doubt it, given all the other conditions that are in the bill.
Before we lose Sebastian, is there anything else you want to ask him about or check in with him about?
I think we're good. I think your proposal that you, and I think running it by Sebastian is a good idea, sort of
Yes, happy
connecting
to do
with
that.
him. Yeah.
Sure.
Sebastian, is there anything else we need to know from your side?
No, but if any members of the committee have any follow-up questions, I'd be happy to take those over email.
Okay. I mean, our goal here is to complete our testimony and to have Jen put together some language that then you also can look at, and then we can, I think probably Tuesday when we come back from town meeting week, we'll be able to look at a final iteration of the bill and then be able to vote it out. That's the goal right now. And in the meantime, Sebastian, you'll be able to look at the change that we've made, and I'll be able to communicate with House Healthcare. So
That
does
sounds
that
great.
sound like, okay, and committee, does that sound like a plan?
There was one more question that you
Okay.
had for yesterday, which was about the Medicare supplement plans and whether you could require coverage for audio only telephone services or affect the reimbursement amounts for the Medigap plans.
Yes, so Medigap plans are dictated by the federal government, and the state can't require any plan changes as far as adding benefits or changing reimbursement.
Darn.
I do have a question for Sebastian before he leaves. So in light of that and the fact that Medicaid may be in or out, and we know that Medicare is out, and we know that the ERISA self-insured plans are likely not part of what we're trying to do here. Are you going to be able to collect data from them if as part of this to because presumably there'll be some kind of audio only in those plans. We just can't dictate what it is or how they reimburse it, but can we still get the data from them?
Sure. So for ERISA plans that are administered by Blue Cross Blue Shield or MVP, we'll be able to get the data for many, if not all, of those plans because they all use the same claims processing system. And for self-insured plans that use Cigna or Aetna to administer claims, it'll be more of a hit or miss kind of thing. Some may, some won't. But I think we'll have a reasonably complete picture of the Vermont market just with our fully insured plans.
Okay, what about Medicare? You will be able to get the data from Medicare covered patients?
We won't be able to get data from Medicare, but
I mean, think of it this way, as long as audio only is allowed by Medicare for coverage, then we could conceivably get the data from primary care or other providers. But if it's not allowed or not covered in a way that is separate audio only, then it wouldn't be available. Is that more?
That's right.
Yeah. Okay. Yeah. So I think, so that does cover that. And it really does depend on what the federal government allows to go forward in many ways.
So
Senator Hooker.
Can I get a clarification on the Medigap
Yep.
provisions? If Medicare covers audio only, but will only pay so much, does Medigap then kick in to pay whatever the state has come up with for that rate?
Medigap plans are basically created by the Centers for Medicare and Medicaid Services.
Yeah.
And while they cover some of the gaps that original Medicare doesn't cover, they don't necessarily line up with every state insurance mandate.
Okay, so there's
And
a
they don't
possibility
always cover
that they-
everything that an insured person would want. That, you
I
know,
know
that,
that.
yeah,
All
all
right.
right. Anything else while Sebastian is here? Okay, good, all right. Sebastian, thank you again. I know your time is gone by, but we're happy to have you here. Jen, is there
Well, happy to
anything
be here.
else? Yeah, good. Jen, is there anything else in the bill that we haven't? It's hard for me when I don't have when I'm not looking at the whole bill on my desk. I do have it on my iPad, but it's a lot easier when I've got my little paper copy when we're doing markup.
I mean, yeah, there's all of the provisions around the provider side, including informed consent. And then there's the data collection. There's the DFR authority to keep adopting emergency rules on telephone triage services. There's what was a conforming change, but is now sort of a standalone change for the telemedicine statute around the reimbursement parity, saying reimbursement parity doesn't have to apply if the insurer and provider have entered into a value-based contract.
Mhm.
And then I will get rid of the reimbursement parity on repeal for audio only, since there is no reimbursement parity.
Right? Okay.
So
Let's- yeah.
that's what's missing.
Yeah, okay.
And I don't know that there were any, somebody had a question that was going to come back up. Senator Hardy, I think, around necessity of receiving services by audio only. Right, that if it was sort of the only way the person could get the services, was that something you were interested in?
Right. Something in yeah.
You're talking about accessibility,
Right.
based on transportation or, that they're unable to get to the provider. So, yeah, you did bring that up.
Right, that the idea that if it is the only way that they can access medical care because of their transportation situation or broadband access or whatever, that, but I don't know. I
don't
was
know.
more thinking about that in the terms of
Clinically appropriate and medically necessary.
exactly, yeah,
Two
and
things.
I don't
So,
know.
I mean, it would be a fairly significant narrowing of what you have right now. With where the way it came to you was putting more of the choice in the patient's hands about whether they elect to receive the services that way, and it's clinically appropriate to do so. So if somebody was more comfortable on the phone, or had a childcare issue or a weather issue, or for whatever reason wanted to receive them, and the provider was comfortable and thought that was clinically appropriate. So that would be just a different approach to make it more narrowly as sort of a necessity or last resort.
So don't you think that is going to be part of some of the considerations that are given for the use of audio only for
I guess
Medic-
this sort of will come out in the access information in the report. When I was concerned about us requiring this be reimbursed at parity,
right?
I was interested in narrowing it because
Right. Okay,
it
I
just
see.
seemed so now that we've gotten rid of that sort of necessity that it be reimbursed at parity, I'm less concerned about narrowing it. So perhaps, and I think that the language we have in the reporting part of it will cover some of the patient access issues that I brought up. So thank you for remembering that, Jen.
Sure.
Okay, so then on the last, the piece that you brought up on informed consent is a section that we haven't looked at, and I want to make sure that we have at least 5 minutes when, because Ameren is here with us. What I'm going to suggest is are we on the informed consent piece? Yes, we are.
Yes.
How many pages is that? Because I read
It goes through A, B, C, D, E. Oh, and then 2, 3, 4,
Yeah.
5.
Well, you know what? Here's what I'm going to suggest. I'm going to suggest, Jen, that you put together the new language and highlight the new language in the audio only piece. And then that you put together the whole bill with all of the flexibility pieces.
Okay.
So we were looking at the entire bill,
Right.
and that we then have that in our hands over town meeting week, including this informed consent piece. Then that we come back on Tuesday after town meeting, and we can ask questions and go through those sections that appear problematic to any one or more of us.
So I was pulling up the informed consent piece for the audio only. Are you talking about the informed consent piece on the telemedicine that the House Healthcare Committee wants you to discuss?
I was, but I'm talking
so
about
that's not what
putting all of that together for us so that we can look at it all in its entirety. And there will be sections that we have spent less time on, but I'm thinking will be less problematic, hopefully. And this will allow the committee a week to review it and bring questions and comments back. I would like to get the bill out as quickly as possible when we're back, but we don't want to neglect any section of the bill.
Okay, and do you want me to highlight what the informed consent issue is in the underlying?
Yes, please.
Bill before?
Yeah.
Okay. Just pull up the right bill. Nope.
Okay.
All right, so this is the regular COVID flexibility bill that we've looked at. And if you remember, so now we're in telemedicine instead of audio only telephone.
Jen,
yes.
Jen, we end today and are on the floor at 11:30. So my suggestion is that we have all of this sent to us as a whole bill, and that we identify those sections, maybe the informed consent on the audio only that we haven't looked at, and the informed consent piece that the House Healthcare has worked on, but include that and identify it, and then allow for us to read through that over the next week. Then when we come back, we can spend a little time on it.
Okay, it is highlighted in there. It just says end 60 days after state of emergency. So you can.
Yeah. Okay, because we have another bill that we would like to vote on right now. So we can talk about what our goal is with this bill. Maybe just let me know if you have questions. We should be okay. Committee, does that fit with where we are right now in the schedule, to have Jen put together the entire bill, and then as you go through it next week, you'll be able to identify those sections that we need to discuss further with Jen. Okay? That's good. But no, thank you, because I think we've gotten to a good place on the part that has been very contentious. And I think you've all done very good work on this. All right. Amron, thank you for being patient. Here you are. We have S48. Is there anything we need to put up now on this? We had language at the end. Can we look at that?
Yes. So for the record, Ameren Abergele Legislative Council, Nellie has posted the amendment, which would change the last section of the compact language in statute. Would you like me to screen share that, or are people going to follow
Yes.
along? I'll screen
No,
share.
I think screen share.
Okay. Is everyone able to see my screen?
Yes.
Yes. Perfect. So this amendment would amend S48 by striking out the last section in the compact language 1648 and replace it with a new 1648. The language in 1648 is the same as S48 currently, except for I have added, you'll see down on page 2, a new subsection C, which says the state administrator shall promptly and prior to a vote of the commission notify the Commissioner of Finance and Management if the commission proposes to pledge the credit of the state of Vermont under subdivision 1647G H3 of this subchapter, or in any way proposes to impose liability on the state for an amount equal to or in excess of $100,000. And then I renumbered subdivision D and E.
Okay. Why don't you can take the screen down? Because we do have this on our iPads. Committee, how does that look to you?
I think it looks good.
You're
Thank you.
muted, Senator Cummings. We're good. Thank you, Senator Hardy. You're good? All right, we're seeing thumbs up. Senator Hardy's good. Senator Cummings, good. Senator Hooker, Senator Terenzini. Oh, bless our hearts. I won't say I don't like it because I do. It's great. All right, committee, do you want to vote on this bill today?
Yes.
Yes. Is there a motion?
I move that we amend S48 with, is it draft number 1.1 as presented to us, and then approve S48 as amended. Is that the proper motion? Something like that?
And send the proposal of amendment to the full Senate. Yes, that's good. That's good. Very good. So the proposal to pass the bill as amended has been offered by Senator Hardy. Is there any discussion? Okay, Mr. Clerk.
Thank you. At this time, as clerk, I'll call for the vote on S48. I'll start with myself. I am a yes vote. Senator Hardy.
Yes.
Senator Cummings.
Yes.
Senator Hooker.
Yes.
Senator Lyons.
Yes.
The clerk has it by a vote of 5-0-0. This passes committee.
Excellent. All right.
That is.
Senator Cummings, do you have an interest in reporting this bill?
I'm going to have a whole bunch of insurance bills I'm up there with. So
Are you reporting all those as well?
I think so. I just was asked to put the captive insurance on the regular insurance.
Oh.
So I think I've got that one.
Okay,
Senator Cummings, I'm happy to report one of the insurance bills. If you want to trade, I don't want to do the captive one, but I'll do the other one. If you want to do
Well,
the,
but they're going to be together in order
they're
to
gonna
get
be
them
together.
out. They're
yeah.
going to be amended.
I see. Well,
I'm
So-
the only one that can.
Okay,
Fluff my
I
way
don't,
to
I, you know, I don't want to hold us up on this
Yeah.
decision, but let's make a decision. Who wants to report the nurse compact bill?
I can do it.
Okay. I mean,
I
you're
mean-
familiar with it in many ways, so,
Yeah.
okay, let's do that.
And it may end up coming to finance.
Well, now that we've done what we've done, it surely may. The
I mean,
amendment-
no, it's the loss of fees. I
Right,
don't know if they'll send it to us or not, but
Right.
it came to us before.
yeah, okay. Oh, it did, okay. And I have not heard back yet from Senator White. I reached out to her a couple of times already. I'll just touch base, as I said before. So, okay, good. That's good. If you're reporting it, and if it does end up going to finance, that keeps it all in one place.
Okay.
All right. All
Emma,
right.
can you send me a clean copy? And the vote was 5-0-0.
Yes, you'll have the amendment, which will be posted on the calendar. And then the underlying bill will be something that you have as well. So it's the amendment that we're reporting.
Okay, we amended the bill. All right.
Yes.
So I
Yeah.
need a clean copy, I guess, of the amendment and probably the base bill to ship up to Secretary Bloomer.
Yes.
We'll send you both of
Okay.
those.
Yeah, if you get me both of those, I'll get them to him and we'll get it on the
Good.
agenda.
And then the other thing is, Amron, I know that last year, Betsy Ann Rask was doing the bill and had a section by section summary that was very helpful. I forgot who reported it. I think it may have been Senator Ingram. So if that is available for Senator Cummings,
That would be very helpful.
I will look for that.
Okay. All right. Whew. Anything else? So this is our last meeting until we get back after town meeting. But please do look for the bill, the draft bill, flexibility bill that will include the informed consent section that we will need to look at when we get back, as well as the entire bill. We want to go through the whole thing and make sure we're comfortable with it. So I will put that on the agenda for Tuesday when we get back. I can't promise that we'll have the time to do it that day. We may have to shift it over to Wednesday a little bit, but we want to vote on that bill as quickly as possible. Okay. Thank you for your good work today. It's been good. We've had good markup time, and I'll see you all later, but in the meantime, enjoy the town meeting week.